Good evening, friends. Thank you, Sushil, for all these opportunities given to us. Not only me, but everyone of us in a platform like you have created. It's a wonderful, wonderful setup which is there. Today we have a CME on a coronary artery calcification, as Dr. Ripen Gupta will talk about more. As we all know, the coronary artery disease is on the rise everywhere in the world, more so in our country. And especially in our country is early onset of coronary artery disease. That is a really pressure on the community at large. So how to prevent, how to identify who is the high risk of the coronary artery disease, and where to intervene to reduce the risk of coronary artery events. So this is a very important thing to understand. We all as a physician, we should know when to intervene. Today we will be hearing Dr. Ripen Gupta. And I just want introduction to give it to everybody here.
Yeah.
Dr. Ripen Gupta is a senior cardiologist in the town. He is working next Smart Saki. He is MBBS from Government College Patiala. He is MD Medicine from Punjab University, Punjab. DM Cardiology King John Medical College, Lucknow, and Fellowship on Interventional Cardiology National Board of Examination. So very well qualified in the field he is working for, and a vast experience in the Government College Patiala, All India Institute of Medical Sciences, King John Medical Lucknow, Scott House Institute. I mean all the prestigious institute in the cardiac services he has been worked for. And he has a vast experience presently in the Mexico, where he is doing, he is basically an interventional cardiologist, but he is a very good physician cardiologist. Whenever I send to patient to him, he gives the right advice when to do what. So we are going to hear from Dr. Ripen how to go ahead with the coronary arteries. Over to you, sir.
Thank you, Dr. Mathur. And thank you, Dr. S K Mathur, for giving me this opportunity. Today I am going to talk on calcified coronary lesions. Now, how does the calcium get into the arteries? So that is a major concern that we are talking of calcium in arteries, we will be talking of cholesterol in the arteries. So whenever there is a cholesterol deposition in the heart arteries, calcium goes as a surrogate marker. It goes along with the cholesterol into the arteries and gets deposited. Now this is also used for diagnostic purpose. We have a calcium scoring done by CT scan, and if the calcium scoring is more, that means there are more blockage in the arteries. But I am talking of a different thing today, that if a patient has a significant blockage in the heart arteries and there is a calcium in the arteries, number one, what are the problems we face as an interventional cardiologist? And a lot of times you refer a patient to us where you ask us, okay doctor, what is the finding? And we say there are 2 arteries blocked, but there is a lot of calcium, so we advise a bypass surgery. We don't want to do a stenting. There could be some risk in stenting because there is a lot of calcium. So you will hear this term calcium again and again whenever you are referring patients to interventional cardiologists for angiography. So I wanted you to have an understanding of what is this calcified arteries mean, what are the implications, what are the problems they can cause, and can we diagnose them? Like sometimes you will hear a case that patient was taken up for angioplasty, they try to put a balloon inside the artery, but the balloon will not inflate because the artery is heavily calcified. So we have some modalities which we can use beforehand. So can those patients be identified beforehand? And we know that these are the patients where the simple angioplasty will not work. We have to use adjunctive therapies. And what are those adjunctive therapies? Because you will hear a lot of things about rotablation, intravascular lithotripsy, laser. So what are those therapies? Because patient will come to you and say, doctor has referred and done a procedure where a balloon was put in, which is 3 lakh rupees. So you will say that angioplasty is 2 lakh rupees, what is this hell of a balloon which is 3 lakh rupees alone? So there is an intravascular lithotripsy balloon right now, which is very, very costly. So I will be talking of those and giving some examples also. So first is, what is the calcium? As I told you, why is the calcium important? Now in various studies, it has been seen that 1/3 of the arteries will have calcium in the blockages. Let's say a patient has 3 arteries, out of which 2 arteries are having blockages, and if you take 100 of these patients, 30% will be having heavily calcified arteries. And if you look at the data here, this is showing the trend. As we have grown in the last 2 decades, we are now doing more complex cases. when we are doing more complex cases, the percentage of calcium or calcified arteries is growing. So we started with something like 24%, that is 1/4 of the arteries were calcified in around 20 years back. Now around 32% of the arteries, that is, they are calcified. So clearly we are dealing with more complex patients. We are doing more complex angioplasties, and so we are doing more patients with calcified arteries. Next slide. And in one of the recent studies, it was shown that Syntax, it's a very big trial, Syntax trial, it was shown that half the patients who were taken up for angioplasty had heavily calcified arteries. We are not talking about mild calcification, we are talking about significant calcium in the arteries. And these were patients who were divided between multivessel angioplasty and bypass. So clearly in a sicker subgroup of patients, you will find a lot of calcium in the arteries. And this trend is going to go higher because we are now dealing with more elderly patients, more diabetic patients, more patients with kidney disease. If you have a renal dysfunction, then calcium is more. And also we are now doing high risk angioplasties, we are doing chip CTOs, and we are doing a tower also. In tower we are putting in a aortic valve using a percutaneous technique. In those patients we want to do angioplasty also. The patients are 80 plus and they have heavily calcified arteries. So then we have to use these therapies which I am going to mention in the next few slides. Now, one is that calcium, we know it becomes more prevalent as you grow older in age. But does this calcium lead to any problems? So this is a very important slide. It is a 1 and 2 years data of around 1400 patients, and the blue line is the patients with non-calcified arteries, and red line is the patient with severe calcium in the arteries. And you can see that over 2 years period, if you have a calcium, chances of complication is double. Next slide. And this again shows the same thing, that if you have a no calcium in the arteries, moderate calcium or severe calcium, the green one is the severe calcium, you have more myocardial infarction, more vessel failure, and major adverse cardiac events are around 4 times higher as compared to patients with less calcium in the arteries. So clearly calcium in the arteries means there will be more problems in the patient. And why so is that because when you are trying to open up artery with a lot of calcium in, the balloon angioplasty cannot be done because the calcium is hard and the balloon is soft. There can be dissection in the heart arteries. The stent will not be positioned in there. If the stent is positioned, it cannot open properly. And if that happens, then you have more of restenosis. So clearly these problems will happen if you have more calcium in the arteries. And this is again a graph which shows that more is the calcium, lesser is the stent expansion in the arteries. So one thing we know now is that calcium is a very important thing. It will happen more as you grow older and you are doing an angiography in a patient with blocked arteries. If it is there, then the patient will have more complication in the next 1 to 2 years if we do an angioplasty in these patients. And if we can assess this calcium and manage it properly, then the complications can be reduced. So this is a logarithm how to manage it, that when we do an angiography, we look for calcium. If the calcium is mild, moderate or severe, if we find a very minimal or mild calcium, then nothing is to be done. And if we have a very severe calcium, then naturally we have to use atherectomy strategies which I will be discussing in the next few slides. But if you have a moderate calcium, where you find that the calcium is not severe but it is not mild also, then there is a very important role of imaging in these patients. Imaging will tell us that whether this calcium is actually severe or not, because sometimes angiographically the calcium may look less but it is more. And in those situations, if we try to do a conventional angioplasty, we will have suboptimal results. So clearly we want to do atherectomy strategy, and for that we have to be prepared, because if we plan to do a rotablation, we need to have a rotablation console in the cath lab. Only then we can do that. So what is the use of imaging in coronary calcium? Now this is a slide which is showing the 3 patients. One is having a mild calcium, here the one is with a moderate calcium, and here is the severe calcium. You can only appreciate the severe calcium because these will not be seen far away, but you can see something here. This is the right coronary artery, you can see calcium on both the sides of the wall. So these are the patients where we know that we will be facing a problem if we don't use any special strategies to manage this patient. But in these patients, moderate calcified patients, we can be fooled into thinking to it as a doing a simple angioplasty and then having complications. So in these patients, we should be using imaging, and we have two good modalities. One is known as intravascular ultrasound, and it is, as the name suggests, is the ultrasound probe which we put inside the heart artery. And these are the kind of pictures we get inside the heart artery. We can see that the patients have, this is a lumen, and we can see the wall of the artery. And OCT is based on light. So this is optical coherence tomography, and here we use light as the mode of therapy, and we can again get a very good picture of inside the heart arteries, and we can make out where is the calcium, where is the blockage, how to manage this. So these are the two imaging modalities which we can use. And out of these two, in one study it was clearly shown that IVUS is a better modality because it gives the calcium, where even the OCT is missing out the calcium. And this is how it looks on that. You can see that this whitish line is the calcium, and this is the calcium arc which is there from around 270 degrees. Here the calcium is 360 degrees. That is present on all the walls of the arteries. And here the calcium is localized to one side. So based on this, we even have a calcium score using an IVUS. And if the score is high, then we know that we have to use special therapies. Now, if this patient, the score was low and conventional angioplasty was done with a good result, stent expansion was 98%. Now, if the patient has a heavily calcified artery and we try a conventional angioplasty, we'll end up with a stent expansion of only 55%. Stent is not fully expanded. In these patients, complication will happen. Peri-procedure MI, patient having restenosis is very, very common. So in these we have to use adjunctive therapies to first prepare the lesion so that we can put the stent properly. So in this way, imaging helps in first deciding the treatment strategy, and once we have use the treatment strategy, whether which is effective or not, and once we have deployed the stent, whether the stent has been deployed properly or not. So all those three things can be assessed with imaging. And if we don't use this imaging therapies and we go ahead with the calcified lesion, we can have impaired stent delivery. Even the polymer on the stent can get abraded, and this can all lead to early and late complications. So these are the various modalities which we have. One is a cutting balloon, as the name suggests, it has blades on the balloon, so which cut the calcium. Then we have high pressure balloons. This is normally balloon is made of one wall. Here it is a double walled balloon, so which can give a very high pressure and break the calcium. Then we have laser. Then we have rotational atherectomy. Orbital atherectomy is there, but not I have not used. Only few cases have been done in India, but it is not a very common modality. And intravascular lithotripsy is the latest technology. Out of which, if we look at the cutting balloon, open NC, rotational atherectomy and intravascular lithotripsy, these four are the commonly used technologies. Where for intravascular lithotripsy, the console is very small and it can be done anywhere. But for rota, you have to have a special console in the lab before you plan the case. So I will discuss all these modalities one by one and show you examples also. Now, high pressure balloon is open NC balloon. This has a two-layer balloon, so it's not a single layer. So once this is two-layer, there is no dog boning. Dog boning means that normally if you take a lesion here and you inflate a balloon, the balloon will inflate here on the edges, but in the calcified area it will not inflate. But if you take this balloon, it will inflate uniformly, so it will break the calcium. So this can be used in patients where the calcium is mild to moderate, not very severe. Now this is a case where simple balloon was tried, the non-NC balloon which we usually have, and it couldn't break the lesion. And this is the IVUS imaging. You can clearly see that the balloon, this is the diameter of the vessel and it is not expanded. The balloon has not opened the lesion well. Now here open NC balloon was used at 40 atmospheres. So once we have done that, you can see that the waste has gone. This area which was not opening properly has become open, and you can see that there is a calcium in the IVUS. You can see there is a calcium break here, and here you can see that the stent when it is put, it is well opposed with a MLA of 7.7, and here we are getting an area of 3.63. So clearly this will work in a patient where mild to moderate calcium is there, and will open up the blockage. Now then there is a cutting balloon. Cutting balloon, as I told you, is a balloon with a blades. These are the blades which are embedded on the balloon. So when we inflate the balloon, these blades will cause these cuts in the arterial wall, and this will lead to breakage of the calcium because they are basically cutting the calcium. So this is a case where again this area, if you look carefully, this artery is okay, and here it is a narrow area. So when a cutting balloon was used and at a low pressure, there is a waist. You can see a waist here. The balloon is open here, but cannot open properly here. But once you have done a high pressure dilatation, the balloon has opened completely. So this has cut that calcium, and that so now the stent can be placed. If we place a stent in this scenario, it will not open completely. So it will open in both the edges, but the middle portion which is calcified will not open. But now if once we have done the cutting balloon and then we place a stent, it will oppose properly, the area derived will be very good, and chances of restenosis is very less. Now coming to rotablation, it is like basically a drill. It is a diamond bulb which is inserted into the heart arteries and rotated at 1.5 to 1.8 lakh RPM, and it drills the calcium, and it works on the principle of differential cutting. Differential cutting means that when the tissue is elastic, this drill will skip that area. But if the area is hard, like where the calcium is there, it will burn that area. Burn that area means it will remove the calcium from that area. So it will not harm the normal areas, and it will ablate the abnormal areas. So, and the particles which it produces are just 5 microns. So they are very, very small, and they are removed from the circulation. So they are even very smaller than the RBC. So they are easily removed by the circulation. And this is how it looks. Now this is a patient. Again you can see here there is a lot of calcium here. And this is a diagram showing the calcium. You can see the calcium all around the artery. We have done a rotablation. What is done is it has removed the calcium here. It has made this area thin. So when we do a balloon dilatation now, there will be calcium crack here and the artery will open. So this is how it works. Again, you can see the artery has a blockage here. This is a bulb. When we advance it at 1.75, we are rotated at 1.8 lakh RPM, and this will remove the calcium. Then we do a dilatation, and this area will open up. You can see here the circumflexural calcium is there, and once we do the burring, again this area will open up with the balloon, because we have to do a balloon to break the calcium. And once we have done that, and you can see this is the calcium here. It is linear calcium all around, but here you can see the cracks. So you have broken the calcium, and then you can place the stent inside that. Orbital atherectomy works on a similar principle. It again has a diamond bar, but it works in a differential way, and system is similar to a rota, but the bar is in a different. This is a eccentric diamond coated crown which rotates inside the artery. So I have not used orbital atherectomy in India. Few centers have used it, but not too many. Rota is one which we use most commonly. Laser again is available in India, done in few centers, but laser is a costly machine and it cannot be transported from one center to another. So it is not used commonly, but it works wonders. Now this is a patient who had a stenting done using a rotablation, and later on he had a restenosis. Now this stenosis is inside the stent. So in these patients we cannot use the rota again, because rota will then burn the stent also. So laser is used in this patient, and you can see that first a balloon dilatation was done, it didn't work, this area didn't open up properly, and then the laser was passed, and after that when the balloon was done, you can see that this balloon has opened nicely. So you can see the difference here. There is a dog boning, that ends are open but middle portion is not expanded properly. Here it has expanded properly. So once this is done, then we can place a stent, then it is an easy job. So this is again showing the same thing, that this is a stenosis here, and post this, and this is a various IVUS imaging. Here you can see that it is concentric, but here you can see there are cracks. You can see that there are cracks in the calcium once the laser has been done. Then coming to the last technology is a shockwave balloon. Now this was devised by a scientist who was just sitting how to make money. So he was looking at various methods. So he read literature that cardiologists are always talking of calcified arteries, calcified arteries. So he connected the points and he thought that we are using lithotripsy for breaking renal stones and they are made of calcium. Cannot we use the same technology? So he took a balloon, put the meters on the balloon and tried to use the same technology ex vivo outside the body, and he could see that calcium is getting broken. So then he made a miniaturized version of the same thing, and with the conventional balloon, the balloon which we use routinely, it is shaped like that only, but it has a meters inside. So when we take the balloon inside the arteries and we press a button on the console, it emits the sound waves. Now these sound waves will break the calcium because they exert a pressure of close to 40 atmosphere when they are, and they will not damage surrounding areas. So our worry is that if you with these sound waves, it can even break the rib also and all, but it is only limited to a few millimeters around that balloon. So this is a very small handy console, and this is a device. It looks like a normal balloon, and when we take it in the artery and inflate and give the sound pressures, the calcium will break. Now this is a case where we can see that the artery is okay here, has a narrowing here, again has a narrowing here. So it is a long disease in this artery, and this is a OCT imaging, and you will see that there is a calcium in this artery at various places. So it is a calcified artery, heavily calcified artery, long disease. Before the shockwave was there, we could have used the rota also, but nowadays once we see a patient like this where we can pass the balloon and the blockage is not that tight to allow the balloon to pass, shockwave is a better therapy according to me because it is less risky. Rota carries risk of perforation and all, which is less with this. Now here the shockwave balloon is taken, inflated, and you can see that initially it is not expanding, but as the shockwaves are given, the calcium will give away and balloon will expand. So you can see this balloon, once we start, is like this, and once we have given the therapy, it was expanded nicely. So same way the whole artery is treated first, and you can see the breaks in the calcium. This after shockwave therapy, there are breaks in the calcium, and then we do a stent implantation, and we are done. So this is a very simple to use technique, very effective, but only downside is that stent should be, the balloon can be delivered to that area. If the artery is very tightly, heavily calcified and very tight blockage is there, then we have to use a rota. Sometimes we use both together also. First we use a rota to make the way for the balloon to be taken, and then take an ideal balloon to crack the calcium. So again we can see here baseline was these are all OCT imaging. So imaging is very, very important. OCT imaging, we can see that calcium is there all around the artery, and once we are in a shock wave, we have created breaks in the calcium, and when we do a stenting, you can see a good circular lumen is achieved. Now these circular lumens we never achieve in a calcified artery because the area which is heavily calcified will not give way. So we will have a D-shaped usually lumen if we don't use these new therapies, and that will lead to more restenosis, more complications. So clearly use of IVL, use of rota has made our life easy in the cath lab. And this is just a logarithm to see how to manage. So first thing is that can a balloon cross? If the balloon can cross, then we have to look how much is the calcium, depending upon which we can plan the procedure. Either use a rotational atherectomy or we can even use IVL. But if the balloon aging population, because of the comorbidities we are seeing every day, and these are the highest risk lesions. So a lot of times I will be refusing the surgery because the calcium is too much, and even rota and all these therapies may not be sufficient for those patients, and I will be writing a bypass surgery. So one of the few cases where despite having all these modalities, we still be referring patients for bypasses when there is a heavily calcium involving the bifurcations. There are multiple bifurcations are there. LED diagonal bifurcation is there. Left main LED LCX bifurcation is there. So all those cases we may still have to refer patient for bypass surgery. Imaging is must because it will diagnose the amount of calcium. It will make us plan the therapy which thing to use, whether it's NC balloon is enough or we have to go with either ROTA or we have to use an IVL. And then after we have decided the therapy, then how to see how the stent is implanted, post implantation is the stent well opposed or not. So all those things are very, very important and they all can be only known by imaging. So if we are doing a heavily calcified artery, we will always prefer to do imaging in those patients. And adjunctive therapies for calcified lesions, as I told you, ROTA, IVL is a new one. So these are all evolving. Newer therapies are coming now. They are planning a laser IVL. This IVL is basically a different strategy. They are not planning laser to do the same role as IVL. So that also is in the works. So I think technology is advancing, so we'll have more better modalities to deal with calcium. So my talk today was to just make you aware about the calcium in the arteries and what are the problems that we face as a cardiologist. So you as a referring physician should understand that when we say there is a lot of calcium and we don't want to do an angioplasty, you should understand our plight and why we are saying so. Thank you.
Very good.
Thank you.
Thank you, Dr. Ripen, for a very nice talk and really explained how the calcium, high level of calcium in the arteries can be handled. Because the angioplasty is the first line of therapy for the coronary artery disease in case of before we send to bypass. Now the newer modalities which Dr. Ripen has explained to us will help us to go more for angioplasty before they send to the bypass surgery. After bypass surgery, also has its own risk or I would say whatever you call it, surgery is surgery. But if you can handle the angioplasty, but my third question, how often you have restenosis post these procedures?
So it is a very important question. If you have a calcified artery, restenosis will be higher. Even if you use adjunctive therapy. As I shown in one of the cases where laser was used, this patient had a calcified artery, therapy was done, and then we have to use a laser. So clearly, restenosis is higher. So that is the reason that if we feel that the complexity is too much, then we may straightaway refer this patient for bypass surgery. But having used all these modalities, especially the imaging, the restenosis rate has become less, but not as normal as the non-calcified.
So restenosis still remains the cause of concern.
It is slightly higher as compared to.
Okay, Dr. Podar.
No, you can answer.
So my only update for this, what we heard today from Dr. Ripen is really definitely and knowledge to us that we have the various modalities before we go for an angioplasty or we refer patient for the coronary artery bypass surgery. So these are very good. So this is another thing is intravascular ultrasound. How useful this is in practice.
So IVAS is a very important thing. IVAS is a tool is very old.
And how often this is carried out in the practice?
You see, in our cath lab we have OCT because the hospital not buy two machines. But IVAS and OCT both are very, very good. As I showed you the benefit of intravascular ultrasound, it is a very good imaging modality. It will guide us in all our complex procedures. Same thing with OCT. Both are using different modalities. One is using light, one is using ultrasound.
Giving the internal picture of the lumen.
So that is helpful in complex regions. Not in routine cases. Routine cases we don't use.
Of course, that is true. The only thing prevention for the calcification to happen, we have all the lifestyle management, control your diabetes, control your lipids, and all those things. Atherosclerosis is the primary cause for getting calcification.
Yeah.
Thank you. Yes.
So, Dr. Ripen, you said in ROTA ablation 1.8 lakh per rotation per minute?
Sir, it depends 1.5 to 1.8 lakh RPM. So it is like a drill going inside the heart artery. So that is the reason it can be risky also. Sometimes the burr can move out of the artery and cause a perforation. So that is the risk we have to And that is the reason we are very careful in using rota. So the bulb size is very carefully planned. We use 0.5 to 0.6, that is the artery size is 3 mm, so we will not use more than 1.6 or 1.75 bulb. So if you use a bigger bulb in a smaller artery, that can also cause trouble.
And rota you will use only when you are not entering, you are not able to enter the artery.
No, in a heavily calcified artery, rota is relatively cheaper than IPL. IPL is in lakhs, it is 3 lakh rupees for the balloon itself, and rota comes to something like 1.5 lakh. So clearly, if the cost is a constraint, then I will prefer rota. If the blockage is such that a balloon cannot be taken there, then
you have to use rota. So rota knife will go inside.
So rota bar will go. First, a wire has to go.
Yes.
On this we slide the rota. So it just packs. So what the rota does is that, let's say this is a lumen. So we will put the rota bar here. It will try to. So then slowly it will slide inside. But for a balloon, it has to go first. Only then it will
Lithotripsy you can use only when you are to enter the balloon inside.
We can enter the balloon. So first we try a normal balloon. If a normal balloon can enter there, only then we take IVL, because that is a 3 lakh balloon. If I open it and cannot place it there, it is wasted. So I'll first take a simple balloon which is there in the cath lab. If that can go, then IVL balloon can also.
Thank you.
The refined way of drilling.
Yes, rota is basically drilling.
Dr. Ripen, after you do the rota, having seen the artery to be very heavily calcified, is there a specific stent that you plan to put which will be probably more appropriate for that patient, or any stent will do?
Sir, this is a very good question. Basically, around 10-15 years back, we used to have different types of stents, but now the newer generation of stents, most of them are very good. And I think the difference between them is marginal. So if we take an MNC stent, I don't feel one is better than another. So any of those which is appropriate for that patient, like length is there, I want a 2.75-32, so it comes only in 1 or 2 company size, so I will be using those one. Otherwise, any stent can be used, but the bed has to be properly prepared, and IVAS and OCT are very helpful in these patients. So once we have done rota, we should always do a balloon delegation to open up the calcium, do imaging to see whether it has opened nicely or not, then only place the stent.
Sir, once you put a stent, and originally because this artery was heavily calcified and there is a fertile soil, there is a milieu for heavy calcification, is this patient vulnerable to heavy calcification in the stent that you put?
Yeah, so this is again a very important question, especially if the stent is not opened properly. It has been seen that the gaps will be now filled by more calcium. So, but once we have removed the calcium, we got a very good lumen. Even if the calcium comes on the edges, it will not obstruct the lumen. So if you have achieved a very good lumen, then this calcium will not go to trouble us. The main problem is that if the calcium, too much calcium is there, then endothelization is not proper. So if you have not made cuts in this calcium, the endothelium cannot come inside and cover the stent, you can say, surface. So these patients are very prone to stent thrombosis and complications.
So there were some stents a couple of years ago, about 4 or 5 years ago, resolved the scaffolds. And one of the criticisms of the scaffolds was that they were inappropriate for heavily calcified arteries. What is the status today? There has been more trials on the scaffolds, and after Resolve 2, there has again been a tendency to use these stents. What is the status today of Resolve in heavily calcified arteries?
Even now they are not recommended. Abbott has not come back again with a newer generation of absorbable scaffold. Indian company which had an absorbable scaffold available 10 years back also has relaunched it, same version, no improvement. So I am a bit skeptical of using these, especially in a heavily calcified artery, because they are thicker. You see, a simple stent will be something like 50 to 60 micron thick. Even Mirrors, which is the Indian company's absorbable scaffold, is 100 microns thick. So this thickness, when we talk of a vessel which is 2.5 millimeter, becomes significant. So in a heavily calcified artery, these scaffold will stick inside the lumen. They will not go get embedded into the artery walls, and they are a source for late complication. That is the reason absorbed trial failed in US.
So my last question. So what is the typical patient with heavily calcified arteries? A diabetic, a smoker, a hyperlipidemic, or a combination of all three?
I think number one is elderly. Number one is elderly, diabetic, CKD. These are the three very important combinations. Smoker is there, but smoker elderly. Young smoker I have never seen calcium.
Okay.
Elderly smoker, calcium is more, but young smoker, calcium is less. Because you see, in younger patients, when we say myocardial infarction is there in a smoker, it is not because of atherosclerosis, it is because of thrombosis. When the same smoker continues to be smoker, and other factors kick in, like diabetes, hypertension, lot of atherosclerosis is there in the arteries, and then the smoking will cause more calcium in the arteries. So, elderly smoker is a proven one.
Sure.
And dietary calcium is no role?
The dietary calcium per se has no role, but the calcium tablets will take, one small study showed that it increases calcium inside the arteries. Because that is we are releasing a large amount of calcium suddenly into the circulation. But so that's why I don't recommend this calcium tablet to my patients. They say, okay, doctor, Shalika take these. I'll say, ask your orthopedician, then I'll only write calcium. But dietary calcium, no problem.
Sir, then I have a very small question. Sir, if we do balloon lithotripsy, whether the stent has to be put at that place or without stent, it is okay?
No, sir. All these technologies are to make the calcium, break the calcium.
Yeah.
But if you don't put a stent, the calcium is going to come back again. So calcium, we have to make the human, like this is a ring. We want to break the ring. Once you have broken the ring, then stent can be delivered. So they cannot be done without stent.
Thank you.
Sir, you are using the rotators. Rotars. The dust produced or the maybe the residue, is it harmful to the distal vessels?
So there is a protocol that when we are using a rota ablation, we cannot do it 15 to 20 seconds or at the most a 30-second run, so that whatever debris are there, they don't choke the distal circulation. So once we have done that, we wait for some time. We go do an angio injection to see whether there is a slow flow or not. Slow flow means that they are clogging the small vessels or not. If there is no slow flow, only then the next run is given. So if I just go on doing rota to remove all the calcium, then I may end with the death on the table.
Can't you use suction device? After rota, you can use suction to...
Sir, problem is that these particles, as I told you, are even smaller than the RBC. It is very difficult to catch them. So no filter will be able to catch. If we put a filter, it will be catching the RBC also. So they are very, very small particles.
And Dr. Ripen, if the vessel ruptures, how do you manage it?
So,
And how do you decide? You said 40 atmospheric pressure. How do you decide how much pressure is required to open a particular vein?
So we never put a 40 straightaway pressure, and we never go with the 40 with a conventional balloon. Because if we go with 40 atmosphere in a conventional balloon, it will open up at the, it will try to inflate in areas where the calcium is less. So naturally it will rupture, that cause a rupture at the angle between the calcium and the non-calcified areas. Because the balloon is going to inflate like a dog bone. Now, these special balloons which we use, open NC, they have a double balloon construction. So they will not lose their shape even if we at 40 atmospheres. So that's why we can use these balloons, but again safely. We don't go straight to 40. We gradually go up 20, 22, 23, 24, and wherever we see the waste is gone, we stop.
How common is the lesion rupture, vessel rupture?
With open NC, the rupture is very less common. When we use our conventional balloons, which use to dog bone, then the chances of vessel rupture was very common.
If it happens, what do you do?
Sir, the simplest thing is to put a covered stent. Now, covered stent is basically a stent with a polyurethane membrane on it. So when we inflate the stent, it will exclude that rupture from the human. So if that is not working, then we have to send the vein for surgery.
Once Dr. Ashok Seth was saying in a conference, I have a better angioplasty or intervention cardiology due to help by surgeon. In my initial stage, I have perforated few arteries which were taken care of by myself. This was a statement in a conference by Dr. Sosi.
So definitely, without a surgeon, you cannot do these complex cases. Without a surgical support. If a doctor says that he has done no rupture in the arteries and never had an emergency bypass done, then he has done not enough cases.
Very good.
So that is there.
Sir, Dr. Ripen, I wanted to ask you this basic question, sir. When you are dealing with calcified arteries, so they are calcified focally, sir, or it is the entire length of the coronary artery which is calcified?
You see, that again varies. Sometimes what happens is the calcium is there in the whole of the artery. Usually it will not be focal. But the area which we want to treat, it can have a focal calcium also, it can be calcified throughout the area. So that's why when we use a rota ablation or we use an IVF, they will work on the whole length of that artery, which we want to put a stent or something.
And sir, Dr. Mangla asked a very pertinent question that when the artery gets ruptured, what do you do? I am sure you pray also, sir.
Sir, I have a few very basic questions. What is the coronary calcium score?
Yeah, so basically, sir, the CT scan is a very sensitive modality in catching calcium. Now, why the calcium scoring was devised? Because one, we know that CT scan can give a small amount of calcium. And whenever atherosclerosis happens in the heart arteries, calcium is a surrogate marker of atherosclerosis. It is a surrogate marker, not a direct marker.
Okay.
So if the calcium score is high in an artery, we know that this artery has a lot of atherosclerosis. Now this atherosclerosis may be focused in one area or maybe throughout the artery. So if it is focused in one area, then it can lead to a severe stenosis. While if it is diffuse, it may not lead to a severe stenosis, but then it is there. So CT calcium scoring cannot tell us whether the blockage, the arteries have significant blockage or not. But higher the score, more is the risk of the patient in having events in the next few years. So that's why in US guidelines for dyslipidemia, they have incorporated calcium scoring in deciding about the statin therapy. But in India, we find it too expensive to do a calcium scoring in all the patients and then decide about the statin therapy. But that is important that if you have a patient where family history is very strong, you have a borderline lipid LDL levels, and you want to decide whether we should give a statin to this patient or not, because his father had an MI at 50 and his Chachaji had an MI at 55. So, and you have an LDL of let's say 149. 149 itself does not merit a statin. But if you do a calcium scoring and it comes more than 100, 100 is a cutoff minimum, and if it comes more than 100, I will be putting the statin in this patient.
It's the same thing as the Agatston scoring.
Yeah, same sense.
And suppose somebody has a normal angiography, but a high calcium score, is it possible?
Yeah.
And if so, what do you advise to such a person?
So, as I told you, calcium can be very eccentrically deposited in the heart artery. It can be uniformly deposited in the artery, so that total calcium score can become high and the blockage may not be that much. Or it can be centrically distributed, that means out of the whole length of the artery, let's say this much is the length of the artery and calcium is only in one portion. So that area can be tightly narrowed also.
Okay.
So if sometimes we have a high calcium score and we take the pill for angio and we find no significant blockage. So we in those patients we have to be very aggressive in lipid lowering so that further atherosclerosis does not happen.
So what else we can do to reduce the calcium score? Any role of vitamin K2?
So those are not proven in trials, though it is mentioned that it can be thought of. But main is lipid lowering. We should aim for an LDL of less than 40.
Less than 40.
Thank you.
In a high risk patient, less than 40.
Dr. Tulsi sir.
Thank you, Dr. Wan. So after those wonderful questions and passionately talk, Dr. Ripen. So let's talk a little about the IVUS versus the intravascular OCT. So which is superior between the two? I believe you are doing the OCT in your center, but how do you compare with IVUS?
Sir, both are very good technologies. Now IVUS has some advantages. It does not require a contrast. So in patients where CKD is there, we don't want to use contrast. We can have 5 runs or 6 runs or 7 runs, no contrast is used. OCT, IVUS advantage is that in osteal lesions, let's say we are doing a left main osteal lesion, IVUS will give a very good picture, while OCT in left main osteal is not very good.
So not only that, probably IVUS is indicated for quantification of left main disease, where routine angio probably would be equivocal, and bifurcation lesions, as you said, probably these are complex lesions also. Directly quantify the percentage of stenosis. Not only that, would give you some insight on the anatomy of the plaque as well. What do you say, sir?
So OCT does a lot of these things also.
Right.
But few things are like a left main is a blind spot for OCT. So especially the osteal left main. And secondly, as I told you, CTOs also, OCT has a very less role, while IVUS has a very good role.
Right.
At the same time, imaging. If you IVUS is a trained operator, because IVUS images are not easy to interpret. Even a lot of cardiologists cannot interpret IVUS imaging, while OCT imaging is less because it is so clear. It is more easy to interpret. So I think that is one of the advantages. The crystal clear imaging we get from OCT are the advantage, but disadvantages, as I told you, are there. So hospital has to decide between the two systems, but whatever system is there, for when we are talking about calcified lesions, or majority 90% of the cases both will work.
Right. So talking about rotational or RA rotational atherectomy versus lithotripsy, IVL. So more dissections, probably more need of cabbage in rotational atherectomy as compared to the IVL, because IVL is spectacular. You see, this is spectacular, better. You see, safest, most predictable, most effective, and probably it's, this is the modality of choice. Would you say IVL? No, but it comes at a steeper price.
No, sir. The only you have to understand.
Dissections are more common.
I'll just tell you my experience.
Yeah.
I use both the technologies. You see, IVL can fool you also.
IVL can
Fool you also.
Yeah.
There were a couple of cases where we could take a balloon and we did an IVL, and then we couldn't deliver a stent. Now, in those patients, we are in a category. ROTA it never happened. So ROTA is a very good technology, and when we talk of dissection and all, so that only happens if you are not using ROTA properly or you are not a good ROTA expert. So ROTA will need more expertise to use, but results are very good, and around 50% of the cases which are heavily calcified, you cannot take a balloon there. I
was referring to the Disrupt CAD3 trial. So that said, any case, IVL seems to be the better choice.
There was a recent head-to-head comparison between the two technologies, and they clearly showed that the MLA achieved with the rotational atherectomy was better. Though I am using more of IVL than rotational atherectomy. But still, I feel rotational atherectomy is a technology which you should master, which you should know, because when you are in a tough situation, only that is going to save you, not IVL.
So my final two questions, Dr. Ripen, would be statins promotes and accelerates coronary calcium, but the plaque volume and the changes in the composition of plaque by making the plaque more fibrous, see, and that is how it increases calcification. But that doesn't mean that this is indeed, it's increases the chances of having your cardiovascular events. So a word on statins increasing calcifications.
So I think if you take that scheme, because basically it is stabilizing the plaque.
Absolutely.
Once it's stabilizing the plaque, there will be some increase in calcium. But what we have seen in our experience, when we do an angio in a patient who is in, let's say we did an angioplasty on a patient, and after 4 or 5 years we have to do again an angioplasty on a patient, and he has been on a good dose of statins. What I see is that cleaner arteries. The arteries are looking much cleaner. So these are all.
Why does that happen?
Yeah, because it has smoothened out the plaques.
Right.
Hardening of the plaque.
And it is replacing
Hardening of the plaque.
So, but the calcium which comes,
the thin fibrous plaque with the
becomes a thick fibrous.
thick fibrous. So that's why increased calcification is seen.
But calcium which comes is very small.
Limited
very small.
Whatever it is, it does accelerate calcification.
But it does not cause that bad.
It doesn't cause. It doesn't
Because
pass.
that calcium can only be seen on a CT mainly, but not visually.
It's a limited
I have never
calcium.
seen increased calcium after statin. More clearer arteries.
Absolutely, there's no doubt. Because it reduces the plaque volume as well. Not only that, it stabilizes plaque. Not only that, probably regresses plaque as well.
The pleomorphic effect of statin is a stabilizing plaque. It makes it harder, so the intraplaque hemorrhage is prevented. That is the biggest cause of non-cardiac arrest. Am I right, sir?
Absolutely. Dr. Ben, probably in our next talk, we'd like to have the treatment of calcifications with the PCSK9 inhibitors and the recent inclisiran as well. What do you say, Dr. Han?
Yeah, sure, sir. Thank you. I think Dr. Tulsi has been extremely kind. Less than 10 minutes of questioning, but some wonderful questions. And he took the bearing out of Dr. Ripen Gupta. He is almost on the edge. But wonderful questioning, let me tell you.
As always, as always.
And I think Dr. Shireen had a question. Dr. Devin, Dr. Shireen had a question. Can we give the mic to her? Congratulations to Dr. Shireen and Dr. Vimal. Dr. Vimal has just landed here from upstairs. Congratulations to you for becoming the Vice President of South Delhi IMA. Come here. You have any work, you ask me, I will get it done for you. My friend, he is my friend. Congratulations. What do you have to say on your wonderful victory?
Sir, it's PFI and sir, you was with me.
So the process is important, you see. Good. We congratulate you. Ma'am, you have a question. Please go ahead.
Sir, being a gynecologist, I just have one query. If a woman, postmenopausal woman of 52 years old, she's having all the symptoms of osteopenia, and she's mildly dyslipidemic, and if she's having positive family history of MI, is it safe to prescribe calcium with K2 to her?
Great question.
Yeah, so as I told you, calcium, if it is used indiscriminately, like patients take pentosip, all the people take pentosip. So it is like taking a calcium also. They want a calcium. All में हम सर एक calcium की tablet लिख दीजिए, दर्द हो रहा है. That is wrong. When you have a definite indication osteopenia, we have to give calcium. I am not saying that. As I told you, I refer my patients to an orthopedic surgeon. I don't say don't take calcium. I say that if you require a calcium, then take it. Don't take unnecessary calcium. We have a tendency like vitamin D has become. Everyone is taking vitamin D, everyone is taking the pentosip, everyone is taking, not knowing the side effects. I think we should all
Each serum level important. Serum vitamin.
Sir, एक second.
Serum vitamin.
Sir, if I have to give a procoagulant to one of my osteopenic post-menopausal women, orthopedic guy is the last guy I would like to consider. I'm sorry if there is anyone who is an orthopedic surgeon here or remotely practicing orthopedics. I think he is the last guy I would like. He knows nothing about statins. He knows nothing about issues with the coronary arteries. So therefore, I think, sir, right since the beginning you came to bat, you have been asking me to be on the striking end, you are on the non-striking end. Only orthopedics, sir. Why refer my cases to orthopedics? I would like to take a call whether to give this guy a procoagulant, and it is a very, very specific question. A post-menopausal osteopenic women, I need to give vitamin K2 with calcium. Sir, you have to answer this question.
Sir, my question was the same.
So I think in this
Pleiotropic question.
Any blood level important? Serum level of vitamin D or calcium?
No. So vitamin D, if the level is we have to supplement, but calcium can be given in this patient. So there is no doubt when you have an indication to give the calcium.
Even vitamin K2.
Yeah.
So there you come. So there is the Dr. Rana has a question. Dr. Rana has a question.
I have a case to discuss. Sir, my question is that people are coming to us and they are asking that what is the good step. For example, if they are having a coronary artery disease and they go to a cardiologist and the cardiologist recommends the step. And they come to us as a family physician. They come to us, sir, आप हमको ये बताइए कि सबसे बढ़िया और अच्छा स्टंट कौन है? कि क्या हमको मेटालिक स्टंट यूज करना है कि हमको डिग्रेडेबल स्टंट यूज करना है। इसका मतलब है कि जो स्टंट हम डालते हैं वो 6 महीने या 1 साल के बाद गल जाता है। तो सर मेरे को खाली इतना बता दीजिएगा, प्लीज हिंदी में आंसर करिएगा सर।
ओके, तो आई जस्ट आंसर। आज से 10 साल पहले we used to have lot of variety of stents which was coming in. One was stent हिंदी में सर। एक वो stent था जिसमें दवाई नहीं होती थी, प्लेन स्टेंट होता था। एक स्टेंट होता था जिसमें दवाई लगी होती थी, जिसे ड्रग लूटिंग स्टेंट कहते हैं। फिर एक नया स्टेंट आया जो प्लास्टिक का बना होता था, जो डिसॉल्व हो जाता था। So the number 1 and 3 option has gone. So there is no bare metal stent. Bare metal stent का मतलब जो बिना दवाई वाला स्टेंट होता है वो खत्म हो गया। और जो absorbable stent है वो इंडियन कंपनी का आ रहा है और with questionable studies done. So that is also out. वो भी out हो गया। अब हमारे पास बच जाता है ड्रग लूटिंग स्टेंट जो मेटल का बना हुआ है, मेटल में अलॉय का बना हुआ है और उसके ऊपर दवाई लगी हुई है जिसको हम इंग्लिश में ड्रग लूटिंग स्टेंट कहते हैं। अब वो स्टेंट आगे 2 में डिवाइड हो जाता है। एक होता है कि जो फॉरेन की कंपनी का बना हुआ है, एक जो होता है इंडियन कंपनी का बना हुआ है। बोथ स्टेंट्स आर गुड, बट इफ यू लुक एट द डाटा जो स्टडीज हुई हैं तो नेचुरली जो स्टेंट यूएस से बन के आया है या जर्मनी से बन के आया है उस पर ज़्यादा स्टडीज हुई है। तो हम और गवर्नमेंट ने दोनों की प्राइस सेम कर दी। इंडियन गवर्नमेंट ने 2016 के बाद कोई भी स्टेंट होगा अगर हम लगाएंगे, चाहे वो इंडियन हो चाहे फॉरेन का हो, उसका एक ही प्राइस है
29,500 से ज़्यादा नहीं
नहीं आप सब 33 कुछ हो गया, ऐसा जो
4 साल बढ़ गया।
मेरे ख्याल से ऐसा कोई क्वेश्चन पूछे तो ये बोलना चाहिए कार्डियोलॉजिस्ट जो बोलते हैं वो लगवा
मुबारक हो।
इसमें हम लोग कह रहे थे कि प्रेफर करें एमएनसी स्टेंट।
दे आर द बेस्ट।
क्लियर कट इंडियन कंपनीज में भी कुछ अच्छी कंपनीज हैं जैसे मैरिल होगी, शाहजहां टेक्नोलॉजी होगी, बट आप नोएडा और क्लियर में बनने लगे तो आई डोंट इवन नो द नेम ऑफ दोस कंपनीज। सो एमएनसी कंपनी का स्टेंट लगवा लो बस।
कार्डियोलॉजिस्ट में छोड़ देना चाहिए।
Last question, Dr. Tulsi sir wants to discuss a case. 5 minutes, sir, I give it to you. We wind up at 10:16.
Thank you, Rashwan. So, Dr. Ripen, an interesting case. A 70-year-old man had a calcium score of 3,500. Had atypical chest pain multiple times. So he was sent for evaluation to a cardiologist. His angiogram was done, which was absolutely pristine. His stress thallium was done, absolutely normal. But his calcium score, which was done earlier, was 3,500 and repeated after a year. Again he had a atypical chest pain and it rose to 4,500. With normal coronaries, stress thallium negative, his LDL was 70, his lipoprotein A was also normal. So how do you infer this case? Echo was normal, the stress echo also was normal.
Coronary arteries. So basically we are having a patient who has a very high calcium score in the arteries, but there is no blockage. You see, as I told you, calcium can spread throughout the arterial wall.
No plaque.
So, it can spread through the arterial wall. It can be there on the surface of the artery also.
So Dr. Ripen, would you say probably we need to investigate this patient for high parathyroid hormone, for CKD with high phosphate levels?
No, that is the other reasons for high calcium.
Blood calcium also.
But I am telling you that why the arteries were normal, because the calcium was on the walls of the arteries.
So would you say, Dr. Ripen, anyone, above the age of 17 males, 90% of the people would have high calcium? No, it is there. And in females, 67% of the females would have high calcium, being asymptomatic, without any coronary artery disease.
They can have calcium, but not very high calcium score.
No, I didn't say that, very high calcium.
So I am getting a lot of CT.
Let's discuss about this case.
Yeah. So in this case, number one is that from coronary perspective, nothing is to be done. So, and secondly, which you are rightly said that we should look for causes of high calcium. So that we are already told. But we have seen cases where the lot of calcium is there in the arteries. Blockages are mild, very mild, but lot of calcium is there.
This is an odd case, it's a rare case, but we should keep this in mind. Thank you, sir.
Can I say something?
Please, sir.
The hyper
and sir, I also want you to summarize this matter of CMP for us.
Sir, hyperparathyroidism is the cause of hypercalcemia. It has to show in the blood also. It cannot be isolated in the coronary arteries. So we have to overall assess the patient, whether the hypercalcemia is there or not. Is there a family history of hyperparathyroidism or not? Hyperparathyroidism is not overnight. It is an insidious onset, it takes time. So anyway, that is a very good question and very good case. We should understand more about that. And rightly said, the coronaries are normal. Dr. Ripen is saying.
Dr. Ripen, any term like microangiopathy?
Yes, microangiopathy is very common. In fact, there was a study done which showed that one-third of patients is having a typical anginal pain. Typical angina will have normal causes. In India, what we say, आपको हार्ट की प्रॉब्लम नहीं था वो, लेकिन मुझे छाती में दर्द हो रहा है सर, उनके नहीं हार्ट नहीं है. US and European cases, they did a study on those patients, and all of them were having microangiopathic angina.
That's what.
So in India it is ignored entity, even by cardiologists.
But they should take precautions.
Okay, sir. We coming to the end of a very interactive CME. And very well talked by Dr. Ripen Gupta. We are very thankful to you, sir. And it was one of the wonderful things we have. Thank you everybody for